Hello everyone. Today we are going to study about the episiotomy. So let's go with the topic. So episiotomy is a surgically planned incision given in the posterior wall of the vagina to provide the way to facilitate the delivery of the head of the fetus. So this is the definition of the episiotomy. So why the episiotomy is given is to increase the like increase the pathway, more widen the pathway, and then to prevent the perineal tear or the rupture of the perineal membrane. What is the preferable time to give the episiotomy is before crowning, or the 3 to 4 centimeter of the head is seen, then it is the best time. And the indication of the episiotomy is big baby, or the history of the perineal tears, perineal surgery, or shoulder dystocia, or rigid perineum, and uh, instrumental delivery. These are the indication of the this episiotomy. So structure cut during the episiotomy is first skin, then superficial or deep perineal transverse perineal muscle, and then bulbospongious muscle, and vaginal mucosa, and levator ani, like fiber of the levator ani muscle, and the perineal knobs, and perineal branch of the pudendal knobs, and the internal pudendal vessels. So these are the structure which is caught during the episiotomy. So what are the type of the episiotomy is like median, mediolateral, lateral, and J-shaped. So why the mediolateral is more preferred, more usually used in the hospitals than median, is that there is no chance of external anal sphincter rupture, but at the median episiotomy there is chance of this external anal sphincter rupture. Like if this is the vagina and then this is the anal sphincter, then if we give the incision in this, then it is median, and if we give of the angle, then it is the median lateral. So if the perineal tear increases its size, then there is chance of rupture of the external anal sphincter and other muscles. But if there is increase of the incision due to the delivery of the baby, there is no chance of external anal sphincter rupture. But the median has more benefits, are pain is less, but here is pain is more, and the bleeding will be less, here is more bleeding, and then repair will be easy. In the repair it will be hard, and then for the healing will be easy, and it take long time for healing in medial lateral. And another thing is in the median, there is no chance of less rare chance of dyspareunia, but here can be some percent chance of dyspareunia seen in the patient who was having mediolateral episiotomy. So the process, let's talk about the process. First, the prerequisite, we have to antiseptic the surrounding by the povidone iodine, and then we have to keep the anesthesia in the fanning out pattern like this. If we have to keep this fanning out pattern, and then we have to use the episiotomy scissor, it is at some angle, this type of scissor, which we have also already talked about in the instrument. And there is protection, for the protection of the head, there is a bulging part, and the tip is also blunted. So this type of scissor is used in the episiotomy, and the two finger is placed where in the vagina where the episiotomy is given, and then one part of the scissor is inside and the other is outside, and then give the episiotomy at the height of the uterine contraction, like to see the perineal muscle more where it can contract. So we have to give the episiotomy at the height of the uterine contraction. So for the repair, so when we have to repair that after removal of the placenta, we have to repair after removal of the placenta, we have to repair. And for the layer of the repair, like skin, firstly like mucosa, and then muscle, and then skin. Then like we have to, if this is the apex of the episiotomy, we have to do the suture from little 2 to 2.5 centimeter above the apex, so that any part will not be left, and it will be like stable suturing. And like in the vaginal mucosa we can give the continuous suture, but in the like muscle layer we have to do the interrupted suture, because like the strength of the muscle will be greater. And if we give the continuous, then if one place, if the rupture of the thread, then all the thread will be gone. So interrupted will be preferable in the muscle layer. And then we have to do in the skin. If we give the like absorbable suture, then we do not have to cut it out, like suture out. But if we have given the not absorbable like nylon or silk, then we have to call for like 6, we have to do the suture out at 6, after the 6 days. So these are the thing. And we have to we have to dressing the like episiotomy site more like at the some interval time after the urination of the patient. And these are the things to be considered in this. So what are the complications are like more bleeding, and the more tear of the perineum, and the infection, and then vulval hematoma is must, we should not left it out, like vulval hematoma. If the vulval hematoma is present, then we have to cut the suture out, and then remove the vulval hematoma, and then again suture it. So these are the thing in the complication, like infection, vulval hematoma, and extension of the incision, and the wound dehiscence. So mostly we have to remember like the indications and the structure caught during the episiotomy, and the what is the difference between median and medial lateral, like benefit and the non-benefit, like adverse things. And then the repair, like layer of the in the repair, and then complication. So these are the things you shall know in the episiotomy. Thank you for watching video. Thank you.